Hello and welcome to today's Hipaa Chat. I'm Carol Flagg with High Tech Answers. Thanks for joining us today. If you're a regular with Hipaa Chat, you know this is a fast and furious hour where we look to answer as many questions as we can based on the topic that we're covering. If you're new to Hipaa Chat, please feel free to ask a question in the dashboard or to reach out to our experts who I'll introduce shortly. Hipaa Chat is sponsored by eFax Corporate, which is a brand of J2. eFax has been in business for many years. They have a number of products dealing with the secure transmission of PHI. So please check out their website, enterprise.efax.com, for more information. We have a number of resources related to Hipaa Chat for both past and future events. You can check out our YouTube channel where we have all of our Hipaa Chats over the last year and a half. You can check out our podcast on our Healthcare Now Radio internet radio station, where you can download the podcast and listen to them on your iPod or listening device. You can also hear a stream live of the show on healthcarenowradio.airtime.pro, and of course you can join our LinkedIn group, Hipaa Chat. If you go to LinkedIn and search on groups, it should pop up. Our experts today that you can pose a question on the right side of the dashboard to are Bob Grant and Mark Heskelson of the Compliancy Group. Bob, Mark, good to have you back again on this month's Hipaa Chat. I'm going to go ahead and turn this over to you, and I'm sure it'll be a fast, furious hour.
All right, Cal, thank you very much. Hey, Bob, do you want to talk about your theme for today first, and then we'll start getting to the questions?
I've got a great theme for everybody. You know, everybody wonders, why do we have HIPAA? Why am I burdened with this? Well, you know why? Because healthcare, and this is going to be my new theme statement for healthcare is set up to breach. We have been. Ever since we've started in healthcare, no matter if you're a small doctor's practice or a hospital or a clinic or whatever you do in healthcare, you're set up to breach. Why? Well, because we email, we fax, we have paper, we have mailings, we have CD-ROMs, we have hard drives. All of this stuff that's mobile and can be moving within our organization and moving outside of our organization, which causes us to have a breach. That being said, that's why in the rule you won't see where it says you must be compliant. It says you have to make a good faith effort because they know that you're going to breach. They know you breach all the time. When I see organizations and I say, have you had a breach? And they say, no, we've never had a breach. You've never had a breach because nobody's ever told you that you had one. So the thing about it is making that good faith effort, making sure that you have all the things that the government's asking you to do and put in place, and if you still have a breach, you're still able to show them I made the good faith effort. So that's why they have different tiers of fines. So just remember this: we are built to breach. It's going to happen. What we have to do as healthcare is we have to make sure we have a great compliance plan in place, and that we're auditing ourselves and we're doing everything the government asks us to do so we can show them we're making a good faith effort. Okay, that's my opening theme there.
That's your opening statement for today. So on that, let us start off with some of the questions we have gotten. Everyone, just as a reminder, you can post your questions on the right-hand side, and you get extra credit if you can stump Hipaa Bob. At least we try to on any given day. Sometimes we do, sometimes we don't. So let's see. The first one is, who do you see most commonly owning the plan? Functional alignment within the organization, compliance, security, IT, risk, etc.
It depends on the size of the organization. So, for example, if you've got a 2-doctor practice with 12 people in it or 1-doctor practice with 6 people in it, it's usually going to be the office manager, right? The office manager is the privacy and security officer. As you get larger and where you have to have some type of IT person, that's, maintaining the servers and the workstations, then you probably have a split there where you have the IT person as the security officer and the office manager is the compliance officer or the privacy officer. As you move larger, where you have a large clinic, maybe with 12 sites, then you end up with a compliance officer, a privacy and security officer, and maybe junior officers at each one of the sites, because there's no way that one person can get to 12 sites. So you have to have people at each site. So as it grows, it could be one person, it could be two, it could be three, it could be five, it could be a team. It just depends on how large your organization is, of what you would have to have in place to maintain compliance.
All right, so let's take the next one. What resources are available to providers to ensure a HIPAA-compliant program is in place? Should they seek consultants for help?
That's a good question. You always have help at HHS, right? Whether it is clear enough for you to be able to do it yourself, that's another story. But they do have documents that will tell you what you need to do on the privacy side, what you need to do on the security side. What they're not going to have, they're not going to give you the policies for it. So you're going to need a company that has, you know, the policies, the procedures, the plan, and maybe some type of tool to track it all in. Shameless plug is that's what we do, but, you know, needless to say, you could get anybody, right? You could do it yourself. If you could build policies, you could do it yourself. But there are documents out there at HHS for you to get the necessary information of how to build a privacy plan, how to build a security plan, how to make sure you audit you do the risk management, you do the risk analysis, what needs to happen, right? And so it will guide you through it. Now, like I said, is it going to be clear enough? Is it going to have everything that you need? Maybe not. You know, and there's different price levels too. So I don't know if you are in a clinic or you're in a hospital where you maybe have a little bit of a deeper pocket, or are you in a small doctor's practice where, wow, funds are tight, right? How much am I going to pay for this? Well, when you start talking consultants, you're talking $150 an hour, and it may be 3-4 weeks that it's going to take them to get that done. So you're looking at, you know, $15,000, $20,000. You're going to be able to do that? You may be, you may be not. So it all depends, number one, on your, first of all, determine what your budget is. Do research on what's out there for you, and then decide what you want to do. But don't just jump into a consultant, because it's going to be, it'll be fairly expensive.
All right. Let's see. Let's take the next one. Okay. Ooh, this is an interesting one, Bob. Not sure if it's going to throw you off. Okay. I work to assist practices in their grant specifications. One requirement in the SIM grant in Colorado is for pediatric practices to collect postpartum depression screenings on mothers. What are the HIPAA implications of collecting this data for someone for whom there is no treatment relationship? That's a good one.
That's a good one. So in that situation, when you are, and that's basically research, okay? So you can do research, right? But you're going to need to have, and depending on what research it is and how the grant is written, you may have to have authorization and disclosure from the patient to release that information. Matter of fact, I suggest that you have it. No matter what the rule says, no matter, oh yeah, you could do research, you know, you're going to want an authorization and disclosure from that patient to participate in that research. So the state, anybody can say whatever they want, but, you know, the state and the federal government, you know, sometimes this rule clashes, right? Sometimes the state is more restrictive than the federal government, which then you have to follow the state law. But in this instance, when you're gathering information and sharing it for research, right, it's best that you get, because that patient has the right to opt out. So you're going to want an authorization and disclosure form. If you don't have one, you can find one online. You can find one at HHS. And you get that patient to sign that it's okay for you to release that information for this research, for this grant. My thing is always, when in doubt, get an authorization form signed. It's so easy. And if the patient opts out, then don't send it. It's not going to affect, one person's not going to affect this research, right? but could affect the practice if they release that information and the patient finds out about it and then complains to HHS. Next, Mark.
Okay, next one. Okay, we are a hospital facility. In the near future, our billers, coders, and insurance verifiers will be working from home. What preparations should the facility take regarding HIPAA concerns for these individuals working from home?
Yikes. Okay. That's almost as bad as BYOD, bring your own device. So you got to hear me out on this one. So as soon as you take that person out of your environment and you put them in their home location, you're still responsible for what goes on there, because they're your employee accessing your data from there. So number one, it's going to depend on how restrictive you can make that workstation at home. Remember now, if that's a BYOD device and not a hospital device that you have there, you might run into situations where kids are logging onto it, right? So you can't. So number one, you have to restrict the access. You have to restrict that they can't print, that they can't use their CD-ROM drives, that they can't print screen, right? So if they want to come up and take a picture of something with their phone, well, you can't stop that. And that's how you have to train the staff and the implications that happen to them on that. But locking down that workstation to where they can't print screen, they can't copy it to the hard drive, they can't copy it to a CD-ROM or any other device. All they could do is just input the information into there. Now, how are they getting that information? Are they getting it by paper? Now you have to provide shredders, because that stuff's going to have to be shredded when it's done. You can't have them just sitting around their house. How are you going to protect that office? Are you going to put a lock on the door? So there's a lot of considerations there that you're going to have to go into some individual's house to protect your stuff. You can't just say, okay, work from home. That's not going to work. You're going to end up with a breach. You're going to end up with somebody breaking into that house, taking that information, taking that system, and then you're going to have to report. So you really should rethink that, unless you're prepared to shell out a few dollars to protect that at each one of their houses, because you are responsible for it.
Okay. Okay, next one. HIPAA mandates that PHI be protected from inadvertent access disclosures, etc., but recognizes that this data can be used for TPO. However, it only applies to HIPAA-covered entities who use the standard covered HIPAA electronic transactions. What about a vendor? Their systems. They are not covered entities, but how do we mandate and monitor adherence of HIPAA privacy and security rules to those entities or these entities?
Okay, so you're a covered entity, and you understand TPO, and you understand that if you have an inadvertent breach, you have to track it, you have to try and mitigate it for the next time, okay? That's great. So that's you. So now you have to have a business associate agreement in place with the business associate, and you need assurances from them that they're complying with the HIPAA security rule, okay? So them being compliant with the HIPAA security rule, and so for them, you know what you have to do. So when you sign somebody and you have them sign the business associate agreement, right, which says they will comply with all pertinent HIPAA laws, whether privacy or security, and you've got this business associate now who is, let's say they're a clearinghouse, they're a billing service, okay? And so you understand that they have information within their four walls, but they also release information out the back end, right? So here you are, here's the business associate, and there's some other business associates that they're using, okay? So they're responsible for signing business associates with the next guy. You're not, right? And this person, when they release information there, they're also responsible for accounting of disclosures. So if they're releasing information for TPO, they can release information for TPO, share away. But if they're releasing information for anything else, they're supposed to be tracking that. And so they would have to have some privacy policies in place, not all of them. You know, for me, I have 21 privacy policies, right? So they would probably have to have about 6 or 7, accounting of disclosures, you know, et cetera, et cetera, et cetera. And so if they release for anything that's not TPO, they're still supposed to track under the law. So you have to do your job, and that business associate agreement that you have in place with them. Here's one of the things about business associate agreements. I'm just going to throw this out there. I think this is a big failure by the government. It's a big failure by the government for not having a standardized business associate agreement, because actually a business associate agreement is a contract. Why is it a contract? Because it tells who is responsible in the case of a breach. And what I have seen over the last 11 years that I've been doing this job that I'm doing, making people compliant, is that I've seen everything under the sun when business associates tried to enforce their business associate on a covered entity. I've seen, I'm not paying for anything, you're paying for it even if I breach. I'm seeing I'll only pay up to this amount. I've seen everything. And so instead of the government making it easy and saying, if you breach, you pay, if we breach you, we pay. That didn't happen. So you have to be really careful with these business associate agreements that you sign, because you think it's just, oh, it's just normal, we just sign it. You need to have a lawyer be looking at those and make sure that that agreement is equal in both ways. Okay? So going back to your question is, as long as you know that you're supposed to track your disclosures, that if that business associate agreement says that they will comply with all HIPAA federal regulations, right? Whether it's privacy security or, you know, breach notification, you know, because they're only going to notify you back, but they will be tracking that. They have to under the law.
Okay, next one. We have a public-facing tracker board so that families can trace the progress of their loved ones through the pre-op, surgery, and post-op. We do so with a case number, which however is still one of the 18 named identifiers. Mm-hmm. Besides the doctor and location, no other information is presented. Are we failing the second test of PHI with this practice? Are there other options or suggestions? The case number is given in writing to the family when the patient with the patient and consent is given.
You run into, you know, you have these 18 fields, right? And you'll have different opinions on what constitutes PHI. You're right. That is a field of PHI. But when you get to the nitty-gritty of it, right, if I stand at that board and I look at a number and I can't tell who the heck it is. I mean, it doesn't say BG9745 where I can say, hey, that might be Bob Grant, right? So if there's no other identifiers in there but some numbers, right, you may be able to say that because there's no other, you know, no other types of identifiers on there but a doctor in a room and a number, you may be able to say that it's not, is it protected health information? Absolutely. But is it identifiable? Not so much, right? So you may have somebody that's going to complain, and in that case, you would have to have, that's an opt-out, right? Well, why? I don't understand why this is up here. That's a violation. Well, then opt them out and don't put them on the board. But, you know, you run into that situation where you're trying to do a good deed for the patients and their families because, you know, their patient, you know, they'd like to know, well, are they getting out? Did everything go good? And it's on the board and it shows them. They know who it is because they've got the number. Nobody else does, right? They just see somebody went into surgery and, you know, somebody came out, right? So, you know, I go back and forth on this every day with people, okay? People will call up and say, well, you know, if we want to, you know, depending on how much information you're putting on that board, So, I might be able, and if I can determine who that person is, then it's going to be a direct level of PHI, right? I mean, there's no getting around it. But if you're restricting it, if you're de-identifying, there's the key word, de-identify. If you're de-identifying it enough that no one would know who that person is, I don't think there should be a problem. But don't get me wrong, somebody may complain.
All right. Now that was a great question, and now it's beginning to prompt a couple other, a whole bunch more. So one of our physicians is the head of research at the hospital.
Yes.
The research team has been given access to our EHR to look for candidates for the research. Of course, the connection is secure, and they were given individual credentials to our system, and they are basically in read-only mode. They have access to all of our providers' patients, not just that one physician. Is this okay?
That's a bad one. That's not okay. So if you, in the practice, were doing the research and they gave you the criteria and then you sent that to the researchers, right? Then okay, I can see that, right? But you have to understand this. What are the, so you just gave somebody access to your system. Okay, you don't know if they've been trained on HIPAA. You saying it's read-only. Can they print? Can they print it to their site? Can they screen print it to their thing? How are they capturing the information? So you don't know who they're capturing or what they're capturing. How many patients do they capture? Yeah, that's not a very good situation. You don't know. You gave them credentials to get in, but you don't know if they understand that they can't share them. What is their background in HIPAA policies, procedures, and training? So you kind of opened yourself up to people having access to your system. So you have to find out, can they print it? What are they gathering? How are they gathering that information? Right? Now, as a patient, I should have an opportunity to opt out, but you didn't give me that. So if one of those researching patients shows up over here and I start getting things in the email about glaucoma, where did you get? Why am I getting this information? Nobody's supposed to know about this. How come I'm getting? And they're going to come at you. And you're going to have to say, well, we gave the researcher, that's not going to fly. Yeah, you need to go back and rethink that one.
All right, this is actually an add-on to the question before. And it was good response and understood, but the Business Associate Agreement, extends the covered entity boundaries to the external entity, but it only applies to me. That's not the problem. I'm a health plan. How do I control what is on the other end of the provider? I have no knowledge of that entity, i.e. biller, i.e. a biller.
Ooh, this goes back to the one where they're going to take the people and put them at home, right?
I believe so, yes.
Okay, so the biller, so you're the health plan and you're putting your billers at home. That's okay, right? Is that? I'm
not 100% sure.
Read the response one more time.
Okay. So understand the business associate extends to the covered entity boundaries to the external entity, but it only applies to me. That's not the problem. I am a health plan. How do I control what is on the other end of the provider? I think what this question is, and the person who posed it, let me ask it this way. Are you implying that you've outsourced it, let's say, to a biller, and if they have subcontractors, what your responsibility is? And if that's the case, Bob, I don't know if you want to explain that. If you have, because that may be, I think, what they mean.
Right. Okay. So if you have a BA with a BA, okay, and that BA is solid and you're sharing the information, and that BA has other BAs that they're signing up behind them, okay, not your problem, not your issue. It is a line. It's you don't have to find out what the other BAs are doing. That's not your job. It's the BA that you hired. It's their job. to get BAs and to monitor their compliance. Not your job. That's never going to bite you. It'll bite the business associate that hired them if there's a breach, because they're going to have to tell the BA, and the BA is going to tell you, and then you're going to report that the BA breached, and then the government's going to come down on the BA, and then they're going to find out that the other BA, so you don't have to worry about that. You only have to make sure that the guy you're sharing with is HIPAA compliant. You don't have to worry about downstream.
Now, and Bob, the person who asked the question gave a little more detail, saying they're the health plan and it is the provider that is using a biller. But I think please confirm if we answered your question for you, and that you're responsible to the person you're sharing the data with.
Right.
They're responsible for who they share to.
Right.
Okay. Okay, next question. As a covered entity, should we do anything above and beyond the business associate agreement to ensure that our BAs are complying and protecting our PHI? For example, should we request to see their policies and procedures, do on-site audits, etc.? Are there any industry best practices regarding this?
Okay. The law specifically states that you do not have to do on-site audits for a BA, but it also says that you should have assurances that they're complying with the HIPAA security rule. So you can ask for their risk analysis. You can send them a security questionnaire. You can, whatever you deem necessary, but it is not necessary to go to their site and audit them. But if you had some type of security questionnaire, maybe the same security questionnaire you had to answer, you pass it on. That's what we do. We pass it on to them. And we say, Mr. Business Associate, how are you complying with this HIPAA security rule? And then they send it back, and you get to look at it and say, okay, this is something I can live with, or this is not something I can live with. These people are not compliant, and I'm sharing data with them. I must stop and find somebody else, or they must become compliant.
And I think one thing that in regards to the omnibus rule, because this has been asked a couple of times of us, and that is, what do you do if you know that the person you're doing business with is actually not compliant, right? And what are your responsibilities? So obviously you should find another vendor if you know that. If you are unable to find another vendor, i.e. there can be some scenarios where we've had clients say, I just don't have a choice. This is my EHR platform. This is my biller. There's so much infrastructure exchange. It's too difficult for me to make a move. You are supposed to report that to the U.S. government. Okay, so if you look at what is under the omnibus rules, those are the type of responsibilities you do have. So the reason I bring it up is if you look at the close to $15 million in fines already this year, the majority of them, at least I would say probably 14 million of them, are related to a BA agreement, failure of a BA agreement, not a comprehensive enough BA agreement, not following your own policies and procedures. So you really do want to be taking this very seriously. Okay, so next one. TPO allows use of PHI without authorization, but the limited data set, DUA, exception to the authorization requirement also lists healthcare operations amongst the use permitted of a limited data set under DUA. Why would operations be stated as permissible use without authorization as a limited data set when operations are already generally permissible use without authorization under TPO? Oh, Bob, I love when they give you good ones.
That is a good one. My stance on TPO, right, is it's simple, right? If it's for treatment, if it's for payment, it's for operations, right? And everybody always asks, well, what's operations, right? It's like, it's like a chart check. It's like a state audit, things like that. Things that you have to do to stay in business, right, would be operations. When it comes to releasing of information, which that's what this is all about, right? When you have, with regards to TPO, there is no limitations, right? So, if instead of trying to delve deep into the quandaries of HIPAA, and how one thing fights with another, like that's what you're talking about here. When one ideology fights with another, it's better just to go back to the basics and say that if it's treatment, payment, or operations, right, I can share the information, right? And if it's anything else, I need an authorization and disclosure form. So I need you to authorize, right? Even if you have limited data sets, right? You know, the only time that you can get away with not having an authorization and disclosure form on limited data sets is if you've de-identified all of it, right? So if you're utilizing patient's name and address and diagnosis and stuff, that's a little more than a limited data set. Is basically the limited information that you're releasing for, for that when you release information for a request. So you still need that authorization and disclosure form signed for that. Now, for treatment, payment, or operations, I can release a lot of information, right, for that, because I may even have to release the whole chart, right? So when you start to break it down to the simplified part. TPO, share information. If I'm going to have limited data sets, which I'm supposed to have, right? People don't even know what limited data sets are. But I have this limited data set, but it's not de-identified, then I want an authorization and disclosure form. So it's really simple. So then, and if it's anything that's not TPO, I also want an authorization and disclosure form. The only time you can release information, right, where none of this stuff happens is if you de-identify it. But if you de-identify all 18 fields, the only thing you're releasing is, I've got 10 glaucoma patients. That's it. That's what it's very simple, right? So I say to the person, break it down to the simplified form and then follow that. Instead of getting all delved up into the regulations and seeing how they contradict each other, don't even do that. Just follow the simplified path. It's the easiest way to go. Mark?
Okay. Yep. No, just bringing it up. Okay. As an HIE, we route and deliver lab results to providers that we get from hospital labs based on the provider of record in the HL7 message. We have a few providers that work in multiple locations. We send the results to the provider at both locations. As we do not know from the HL7 lab message received from the hospital which location or office that patient is seen at, we have BAA agreements with all the organizations in this scenario. Do you think this is an issue?
You have a BA. All right, so when they sign up, so the doctor's office signs up to use your service, okay? And so you got a BA with them to share information. And no matter what location they're at, you covered it with that BA. That's what I'm assuming here, okay? So through an HL7, they send the request in, the patient goes, gets the blood drawn at the hospital, and they send the results back through the HL7 to an office. Because it doesn't really know what office is, but they know what system it's going to. That's what I'm assuming here, right? So you're sending it to some system that requested the service. I don't see a problem there, right? So you're actually, to tell you the truth, labs are covered entities. You're a covered entity. The only thing really the BA is protecting you on is that you're basically covering yourself because you don't know who it's going back to, right? And would the government have a problem with that? Maybe, depending on if there's a breach, right? So as long as the results that are so you send the HL7 request, the HL7 results come back, as long as they're going to the appropriate system that the agreement says that what you're supposed to be doing, I don't see a problem with that. But actually, you really don't even need a BA because it's covered entity to covered entity, right? And it's for treatment. but I see why you have one. I see why I probably would have one too, because you actually, in your answer, you even said, we don't really know we're just sending it to a system, right? So I see why you're doing it, but it's more of a confidentiality agreement than a BA. Next question. I'm sure somebody's going to come back with that one.
No, well, listen. This is probably, out of all the different events we do, these are probably the deepest questions we've seen. Most of the time, they're rather high level, so it's interesting to get, and we appreciate you asking the tough questions. So, okay, next one. We have a provider that is leaving the practice and moving down the street. He wants all his patients' records, about 3,000. We understand this is not going to be compliant. Is a request from his new office starting date to be seen a lawful release for the records, or should we have every patient sign a release? That's right. There's one more question. The provider is afraid of his patient calling for a refill or medical question and would not be able to treat them. Would not have time to get the records on such short notice.
Well,
that's it.
I understand that. So yeah, that's a great concern. Problem is that even though he's doctor of record, he doesn't own the records, right? The office owns it. So he's going to have to send out, before he leaves, he's going to have to send out to all of his patients an auth and disclosure form that needs to be signed and presented to the office that says that they can release the information to his new office. So it really depends, too, on the agreement that the office had with the doctor when he came on board, too, right? Does it say that the practice owns the file, or does it say that the doctor owns the file? So there's a lot of lawyer things going on here that the lawyer, the practice attorney needs to look into to find out first who owns the chart. If the doctor owns the chart, then it can go with them. If the doctor doesn't own the chart and the practice owns it, then you have to send out an authorization and disclosure form to the patient and say, do you authorize, your chart going with Dr. Jones, or do you want it to stay here? Some patients may say, I want to stay there. So you can't just ship them all off without asking the patient.
Okay. All right. When the facility receives potential concerns regarding HIPAA incidences, an investigation is immediately performed. Is the facility required to also complete a breach tool risk assessment for each incident to determine whether reporting is necessary? What best practices should be followed upon receipt of a potential incident?
Okay, that's a good one. Okay, so you receive from somebody, right, that a breach has occurred. We fax something to Joe's Bar and Grill. Let's just take that for an example. Okay, so what I have to do is I have to track that happened. I have to do an investigation. I have to do remediation. I may, if it's severe enough, I may have to do a risk analysis on that situation. And then I have to come up with some resolution so it doesn't happen again. Those are called incidental breaches. That's anywhere from 1 to 499. Okay? So I have this, so I go and I have this, I do these breaches, right? And I have them and I have them and I have them. You're required by law to report those incidental breaches before March 31st of the next year. You have to report the incident, you have to report the investigation, you have to report what you did to resolve it, and any other things, and you're supposed to report those to HHS before March 31st of next year. If it tips the line and goes over 500, then you have to report immediately. And then you have to report to them, and you're going to have to go to the media and all that stuff. So you need to have a breach notification policy in place. The breach notification policy needs to outline everything that I was just talking about right now, And so you should have some type of tracking tool that's tracking this so that you can easily extract the information to give to the government. Really, it depends on the severity, right? Is it incidental or is it a major, right?
Okay. Next one. We do clinical information exchange HL7 with hospitals and other facilities. We do not require a BA. To your point, we are both covered entities. However, we do execute a data use agreement, which highlights which data we are sharing and what we, the health plan, will do with it. We also apply all data privacy and security protocols. So I'm not sure if that is a statement or a question. Bob, what do you think about that?
Well, that's exactly a data use agreement is like a confidentiality agreement, right? We're sharing this information with you because we're trying to do this covered entity to covered entity, and the confidentiality is that you'll keep it confidential on your side. The data use agreement is like that. Okay, so that's exactly what they're supposed to be doing.
Right. All right.
I don't see anything. I don't see anything. There's nothing different they have to do there.
Perfect. All right, let's take, we got more questions. We will keep feeding them out. Okay. Sorry, the person said, did write lots. LOL, it's a statement, but thank you. There's a lot of these that go by me, so forgive me. There's a lot that are going by me at one time, so sometimes I start reading them and realize as I get halfway through that I'm like, oh, okay. Okay, so let's take, there's a couple of kind of more straightforward ones that we have, which is, what is the most critical area to focus on in a security plan?
Oh, that's a good one. Okay, I'm just going to give you the synopsis here of a plan, okay? And then you can determine what you think is the most, okay? So number one, you have to do a risk analysis. The risk analysis is looking at your workstations, how you set them up, your servers, your routers, your firewalls, your wireless routers, your VPNs, making sure that you do some type of vulnerability scan from the outside coming in to see if there's any deficiencies, right? So that's like the IT risk analysis. Then you need to look at each individual device, making sure that each device has antivirus, if it has strong passwords, that you have malware, right? That also, if it's mobile, like a laptop, it's encrypted, right? And I'm looking at every device that not just storing, but also accessing, right? So if it's accessing or storing, it has to have certain protections on it, right? So now I've looked at the IT side of it. I've looked at my main stuff where I'm accessing and my devices. Now, I need to look at my physical site, right? Because you can get dinged on physical site. For example, you don't put an alarm system in, and you go away for 4 days, and they kick the door in, and on the second day, and you come back and your office looks like Cindy Who's house after the Grinch has been there. You're going to be in trouble, because they're going to say to you, how do you think that was protecting the data by not putting any physical protection up? A lock is not a physical protection. So I don't care if it's a cheap alarm system from Walmart, as long as if somebody breaks in and there's motion and it calls the police, fantastic, right? So you can say, I made a good faith effort, didn't I? Yes. Okay. So physically, making sure you have an alarm system, making sure that all paper gets shredded properly, make sure their fax machines and your printers are protected. All this stuff within your 4 walls. So now I've looked at technical, I've looked at physical, now I have to look at administrative. Making sure that I have policies and procedures covering all aspects of the rule for privacy and security. Making sure that I have a HIPAA 101 training. Making sure that my staff has attested to that. Well, what does attest mean? Well, it's not giving them a 4-inch binder with a page on top and says, after you get done reading this, sign the top of this that you understand it. That ain't going to fly. I mean, I bet you everybody on this call has got that, and when the person walked away, they looked at it and said, I'm not reading that. I'm just signing this and giving it back to them. Everybody's done that, right? That's not good in HIPAA. Yeah, if it's your office policies, well, maybe it's not good, maybe it is, right? But if it's HIPAA, it's not good. Because what's going to happen is that person's going to breach and say, did you see that manual? Did you really think I was going to read it? I didn't understand. It was too much time, whatever. They're going to blame you. So what you want to do is have some type of tool that brings up your policy, they read it, and then they tell you they understand it electronically, so you can whip that report out and say, look, you said you understood it. Now you're telling me you didn't, but I gave you the opportunity online to tell me you didn't, right? So I'm going to have policies and procedures covering all aspects of the rule. I'm going to have the attestation side that my staff has been trained. That is a compliance plan. So you're looking for, a compliance program. I've got my administrative, my physical, and physical, and I've got it covered, and I do it every year. Every year I do audits, I train, every year. I track, I'm doing everything that I can possibly do. That's your plan. That's what keeps you in the lower tier 1, which is $100 if they find something wrong, rather than 10 or 20 or 50,000, right? You don't want to be anywhere in those upper tiers. So is it work? Absolutely. Did I sign up for this? Absolutely not. It's just what it is. You have to do it. If you don't want to be, because remember what was my opening statement here? We are built to breach. So if you think you're never going to have a breach, you're wrong. And if you don't have all the things that I was just talking about, you're going to get fined. Okay, off my soapbox.
It's always fun when you're on your soapbox.
I know.
Okay, so good question. What actually constitutes a minor breach? Are we supposed to report when a fax accidentally gets faxed to the wrong doctor? I log those when told about them, but have never reported. We only had we have only had low risk where data was not intentionally obtained but accidentally, and it was resolved, and I logged the incident. I tried to report these but couldn't because they seemed to only want breaches that were at high risk.
There is a place on there that has low risk breaches, and you'll find that that before March 31st of next year, when we get towards the end of this year, HHS will start posting things that say, don't forget to post your incidental breaches. So if you're tracking them now, there will be a place for you to report them. An incidental breach is just like you said. I faxed something to Joe's Bar and Grill. I mailed something and it came back opened and it said not at this address. You don't want to end up with I lost a jump drive or a CD-ROM or things like that. Right, so incidental breaches are where it's less than 500, 499 or under, and there wasn't a huge impact in the data that was breached, right? But if you sent 200 AIDS patients and it went to Joe's Bar and Grill, yeah, you're going to have to report that one, even though it's not 500.
Okay, next one. This isn't a weird one. Well, I'm sorry. Interesting question. What does ONC believe they will learn in conducting a privacy audit?
Okay, what they're going to learn is, do you have the proper policies and procedures in place to direct you on how to release information? Do you have the proper policy in place to allow a patient to amend their medical record? And that one blows me away. But yes, I can come in and get a copy of my medical record. You can't deny me, even if I owe you money. And I can go through my medical record and say, this isn't true. I don't know. That's not right. I want you to change that. And they could make an authorization and request for you to change my medical record. So they're going to be looking at the intricacies of the privacy rule and how you have implemented that within your practice. That was just one of the things that they would be looking for.
Okay. What are other ways organizations are enhancing their awareness and training as it relates to their HIPAA policies and procedures?
Direct online attestation is the one thing that I see people doing the most. And that is where the individual logs in by themselves on their, instead of in a training room. Because let me tell you something, and everybody here knows this. If you do a classroom training, especially at this time of year, everyone's looking outside the window going, oh man, I wish I was at the beach. Wow, I wish, God, I can't wait for my vacation to start. Ooh, this is, oh my gosh, this is so boring. I just can't wait for this to get done. They're not listening to a word this person's saying. They could care less of what's going on. But if you put a disclaimer up that says your job relies on this, of you knowing this, and making sure that you're not the one that breaches, that you could be fired, you watch how fast people will read those. And they will look right online and they will attest that they understand it, right? So you have to put it forth to them that your job is relying on you understanding these policies, because if you breach, I have the right under the HIPAA federal regulations, under the sanction policy. If you don't have a sanction policy, then this doesn't work, but it's required under Medicare and HHS to have a sanction policy. I could fire you on the spot for violating HIPAA federal rules. So having that sanction policy along with, so it kind of like, I'm telling you right now, the privacy and security policies, even though they look like they're all individuals, they all kind of intertwine with each other and kind of handhold each other. This privacy policy, if you breach this, then your security sanction policy comes up. I mean, so yeah, making sure that you have that attestation, because look, if I'm an employee of yours and I do something wrong, I'm going to blame you. I'm going to blame you for the failure of training, because I don't want my job to be in jeopardy. Why should my job be in jeopardy? I don't feel I got trained properly. I don't feel that you provided me the proper documentation. Oh, you gave me a book, but they're going to try and push this back on you, and you don't want that. You want that report that you slap on the table and say, right here, you said on this date and time that you understood this policy. There's no getting around it. You don't want any open holes where people can crawl out of. Because if you can't hold them accountable, then you're not accountable and the government's going to fine you. Especially if it's a major breach, right? Okay, Mark.
Okay. Do we still report every fax that gets sent to a physician's office where the PT may not be a patient there any longer? I thought since they are under the same HIPAA laws as us, that they have the duty not to disclose and destroy it.
Oh, they don't. They do have the duty to do that, right? And they're supposed to destroy it, but you still have to track it that it happened, and you still have to report at the end of the year. So you have to say, we faxed this, the patient no longer there. Maybe our resolution is we contact before we send information from now on, and then that's what's going to get reported to the government. Look, the government knows you breach. They know. They just want you to report it. They want people to report, and what did you do to resolve?
Okay, next question. We have providers going into schools and providing services. Do we need a BA with each school?
No. Well,
that was an easy one.
yeah. Well, no, let me think about this, okay? My wife is a school secretary, so this is why I know this one. So So
under more, or?
under FERPA, right? Under FERPA, which is different, the schools run. And this is another one of those things that make me laugh, because this is where, oh, I thought this would be HIPAA. No, it's FERPA. Same thing with colleges. If you've got a student going to a health center on a college, that's not covered by HIPAA. That's covered by FERPA. Same thing with if you've got employees that are going to workman's comp. Nope. Go ahead and share away, because workers' comp is what? Not covered under HIPAA. So you've got situations that you, as a privacy and security officer, have to understand that it's okay to do that. So no, you do not have to, because they're under a completely different law. Now, if the doctor brings back the information to your site, you're responsible to protect it. But if he's leaving all the information there at the school, no.
Okay. So, in an arrangement where a covered entity is sharing and EMR with another covered entity, what, if any, sharing of risk analysis is appropriate? So, you're not going to like this one.
Oh my gosh. Okay. So I have these happen all the time, right? We wanted to cut down on costs, so we have one EHR covering both of our practices that are in one thing, and we share receptionists. We have receptionists right here and everything. And one side is becoming compliant on HIPAA, and the other side isn't. They don't want to pay for it. They don't want to hear anything about HIPAA. The doctor doesn't believe that anything will ever happen to him. So he's not going to become HIPAA compliant, but this office wants to. Impossible. How can you do that? How can I train my staff and everything, but I still have this doctor over here who's right next to it? When my patients walk up, they have no policies, no procedures of keeping confidentiality over here. What can I do? Right? So the only way to do that is to separate out, build a wall, do whatever you have to do, or make that doctor become compliant, or have him sign a business associate agreement, which means he still has to become compliant, but he won't do it. So now that business associate agreement is not even as good as the paper it's written on. So those situations are no good. It's a fine waiting to happen, because you're going to try to be compliant, and this guy over here, if he breaches, the government's going to come back to you, and they're going to say, well, wait, why aren't you both compliant? Why did you allow this to continue on? Why didn't you do something about it? And you're going to be sitting there going, well, because I tried to save a few dollars. That doesn't fly with them, right? So you really need both sides to say we're going to be HIPAA compliant. You run the issue of, wait, one more other thing too. Even if you both become HIPAA compliant, you still run that issue of commingling patients on your EHR, right? So you would have to figure out a way to separate them out. That probably could be easily done by the EHR company. But both sides would have to have the administrative, technical, and physical audits completed.
All right, so everybody, thank you very much for joining us today. We're up on the hour. Thank you to eFax and J2 Global and High Tech Answers for giving Bob and I the opportunity to answer your questions. In summary, listen, this is, of all the years we've ever seen, this is the year that enforcement is really beginning. So you do want to get these loose ends tightened up. And hopefully these chats are helping us. So thank you for having all these great detailed questions. It definitely makes it a little more interesting when we get outside of the standard, what's the definition of a BA type thing, although it is our pleasure to answer any of the above. So Bob, thanks. Carol, thanks. And have an awesome day, everybody.